speech, I pray thee, as I pronounced it to you, trippingly on the tongue. Can't listen to myself saying it again. There we go. Add item. So now hit publish. Yay! There we are. Chapter 22, Respiratory System Infections and Overview. There's some specific topics in here I would love to spend a lot more time on, but alas, we cannot. Okay, so that looks, I look framed adequately. And this mic isn't working like it did before, but it sounds like it's okay in my monitor. So hopefully it's okay out there as well. Okay, now let's get to this. Speak the speech I pray thee is. Why am I forgetting that? It's from Hamlet. Okay. So, respiratory system infections. We have some current issues out there in the world right now around respiratory tract infections. So anyway, the respiratory tract is one of our portals of entry, right? And this is made more obvious by the fact that we take like 20,000 breaths each day on average. So about 10 cubic meters of air. And suspended within this volume of air are millions of microbes, terrestrial, animal, human origin, including many potential pathogens. A few of these will cause relatively mild infections like sore throats or colds. Others are less benign, like tuberculosis, influenza, pneumonia. Those were responsible for more than 4 million deaths worldwide in 2012. At one time, it was thought that antimicrobial drugs and preventative vaccines might hold respiratory infections in check in the developed world. Recent developments suggest otherwise. The rise of multiple antibiotic resistance in organisms like Mycobacterium tuberculosis has rendered many of our modern drugs ineffective. In addition, there has been a recent resurgence in diseases like whooping cough and measles, once common childhood illnesses made rare by effective vaccines. Despite advances in medicine and public health programs, it is likely that respiratory pathogens will remain formidable adversaries for the foreseeable future. Chapter outline. So anatomy and normal microbiota, and then bacterial infections, viral infections, and fungal infections of the respiratory tract. Section 1, anatomy and normal microbiota. So we're going to look at the major anatomical features, describe the normal microbiota of the upper and lower respiratory tracts, how microorganisms overcome defenses, explain how microbes and the respiratory system interact and modify each other in healthy individuals during an infection. Clinical focus, part 1. John, 65-year-old man with asthma and type 2 diabetes, works as a sales associate at a local home improvement store. Recently he's beginning to feel quite ill, so he made an appointment. Let's see, headache, chest pain, coughing, shortness of breath. Over the past day, he has also experienced some nausea and diarrhea, and he was running a fever of 104, and he just kind of felt, well, I guess it does say quite ill, but 104, that's rough. John suggested that he must have a case of influenza and regretted that he had put off getting his flu vaccine this year. After listening to John's breathing through a stethoscope, the physician ordered a chest radiograph and collected blood, urine, and sputum samples. What factors may have contributed to John's illness? You don't have to answer that. So the upper respiratory system, don't forget the ear, because we have the ear canal, which does connect the tympanic cavity with the eustachian tube and the nasopharynx. And they have the cochlea there, and our tympanic membrane, our eardrum, and our upper respiratory tract. Now, what we've mentioned, hopefully, I expect was mentioned in lab, was the nasopharynx and the oropharynx. So these spaces at the back of the sinus cavity and the back of the throat, effectively there. And let's see, remember your epiglottis and our esophagus versus the trachea, and then the tongue and all the other major features. But the nasolacrimal duct, remember that it's accepting the drainage from the eyes. And yeah, that's fine. I'm not going to make you label these or anything, but keep in mind those major features. That's the upper. Now, so here's the lower respiratory system. So it begins below the epiglottis. There we go. That's where we separate the upper and the lower. And so we have the trachea, we have our cartilaginous tube extending down from the larynx, and unobstructed path for airflow. So the trachea splits into the left and the right bronchi as it reaches the lungs, and then we continue to branch off into more extensive networks of tubes, the bronchioles. Where we at? There we go. That's where we're putting that on the cartoon. And then they eventually terminate in terminal bronchioles. So they're basically cul-de-sacs called the alveoli. So this is where air exchange takes place. So human lungs contain on the order of 400 million alveoli. So the outer surface of the lung, another feature here, is a double-layered pleural membrane, and it protects the lungs and provides lubrication to permit the lungs to move easily during respiration. Yep. All right, defenses of the respiratory tract. So first of all, you have the viscosity and the acidity of the mucosal secretions will inhibit microbial attachment to the underlying cells. I mean, you have literally, wait, is this showing there's the inner space of the trachea, there's the cilia. Okay. So the cilia move, right? And that forms our mucociliary escalator. There we go. And then when microbes are eliminated in this way, that's the mucociliary escalator effect. So normally the beating cilia will dislodge and propel the mucus that has trapped the microbes that you've inhaled, where it is deposited into the towards the epiglottis to essentially be swallowed. So we swallow the mucus coming up the escalator. So the upper respiratory system is under constant surveillance by mucosa-associated lymphoid tissue, or a MALT for short. This includes the tonsils and the adenoids. The other defenses include secreted antibodies, so our IgA, lysozyme, surfactant, antimicrobial peptides, which you've heard of before, called defensins. Meanwhile, the lower respiratory tract is protected by alveolar macrophages. Alveolar macrophages. There we are. So, given all that, there are still normal microbiota of the respiratory system. In the upper respiratory system, so like in the nasal passages and sinuses, we have these groups of bacteria, the Firmicutes, the actinobacteria, proteobacteria, including Staphylococcus epidermidis, and the viridans group of Streptococci, Corynebacterium, Propionibacterium, and Haemophilus. Yeah, so that's the nasal passages and the sinuses. In the oropharynx, so the back of our throat, you got the same plus some extra. These guys, Moraxella, including Moraxella. Okay, there's a disease associated with the Morixella that I'm not going to talk about in here, but just reminded me of cheese making. Okay. Candida fungal isolates can also be found there, along with other genera. About 20% of the population carry Staphylococcus aureus. The pharynx can be colonized with pathogenic strains of Streptococcus, Haemophilus, and Diphtheria. So let's see. Fusobacterium, yeah, that's mentioned there. So, as with the eye, when we talk about the lower respiratory system, for one, we can find these genera there, but not in high densities. So it's scantily populated, and therefore it's not clear if these are just transient microbiota or if it's, long-term populated by these genera. All right, so summary of some important respiratory diseases and their vaccines. So chickenpox, which will cause shingles later on if you actually have it. There's a chickenpox vaccine which was first available in 1994. I think it was 94. Most of y'all hopefully had it. My kids certainly have. And there's a shingles vaccine that I'm actually too young for, but I will get that when I can. Rhinovirus is generally the pathogen that causes the common cold. We have diphtheria, Corynebacterium diphtheriae here, which there's a variety of vaccines available for it. It sounds like somebody hit my car, but I hope not. Okay, so DTaP. The diphtheria is the D. Yeah. Okay. The diphtheria is the D in each of these. Different formulations there. So, Haemophilus influenza causes epiglottitis, otitis media generally, or commonly can be caused by Haemophilus. There's the Hib vaccine for that. Influenza, there's a new trial I'm going to tell you about when we get there. But, we have the basic seasonal shot or the flu mist. Measles, of course, is part of the MMR. Pertussis is the P and the DTaP and the Tdap. Pneumonia, there's a couple of different pneumococcal vaccines available. Rubella, German measles, is also available with the MMR. SARS has no vaccine. And tuberculosis has a BCG vaccine, which most people don't get. A lot of people in the military can, but only if they're going to be deployed in an area where it is endemic. And as far as I know, I never got that. I would probably know if I did. Well, I mean, that first day, like P2 day or whatever, you'd been there for less than 24 hours at boot camp processing. They run you through a line and they hit you with injectors from both sides. So, unless I looked at my record, I'm pretty sure I did not. And maybe there's something distinctive about that experience that where I would know. Yeah. Okay. I also heard that these days in boot camp they could do this at MEPS actually. They could do this beforehand when they do the initial physical stuff. They could test your vaccine titers, look for antibodies, circulating antibodies that are commonly raised against those pathogens that you're vaccinated against. Then they can tailor that a little more. Okay, so some of the terminology around respiratory infections: rhinitis, nasal cavity inflammation; sinusitis, inflammation of the sinus; otitis is for the ear; pharyngitis, sore throat; laryngitis, larynx; tonsillitis, epiglottitis, bronchitis, right? Pneumonia is a generalized term that describes any condition that has caused the alveoli to become infected and inflamed, like fluid filled, and that is generally pus, and they'll swell, right? Like all the cytokines and whatnot that are released will cause that. Okay. A case in point: smoking-associated pneumonia. So let's see. Camilla is a 22-year-old student who has been a chronic smoker for 5 years. Recently, she developed a persistent cough. She got an X-ray. Strep pneumonia was isolated from her sputum. Smokers are at greater risk of developing pneumonia than the general population. And let's see, because of impairment of the lungs' immune defenses. So the ciliated epithelial cells get disrupted, phagocytosis, and antimicrobial peptides get blocked. And so in total, you get a dysfunction of the mucociliary escalator. And yeah. All right, so bacterial infections. Oh, wait, I was going to say something about that. I did smoke for longer than I'm going to admit, but never really had the smoker cough. I mean, I knew people that did that would smoke like 2 packs a day, and they sounded awful. I actually knew a guy in A school that would get up at like midnight or 2 a.m. just to smoke. All right, bacterial infections. Looking at more specific bacterial infections of the upper and lower respiratory tract. So streptococcal infections, Streptococcus pyogenes, of course, and this is colorized SEM. And yeah, chains of cocci. That's all we're looking at there. But let's see, it's caused. So Rebecca Lansfield is the researcher that classified the streptococci in the late 1930s using carbohydrate antigens from the bacterial cell wall. Strep pyogenes is the sole member of Lansfield Group A, often referred to as GAS, G-A-S, Group A strep. And culturing to diagnose this is the gold standard. Probably still. It hasn't changed in the last couple of years, maybe. Anyway, strep throat. Streptococcal pharyngitis. Oh, and here's what that looks like on the back of the throat. So this is characteristic of the of strep throat. These spots back here, bright red arches of inflammation with the presence of dark red spots, so petechia. So many strains of strep pyogenes can degrade connective tissue using hyaluronidases, collagenases, streptokinase. Streptokinase will activate plasmin, which will induce the degradation of fibrin, causing the dissolution of blood clots, and that helps them spread, as mentioned in virulence factors, right? So the classic signs of streptococcal pharyngitis are a fever higher than 100, intense pharyngeal pain, which if most people have had this at some point in their lives. Back of the throat really hurts. And let's see, often dotted with the back of the throat, often dotted with patches of pus and petechia, which again, the microcapillary hemorrhages on the soft or hard palate of the mouth. And the lymph nodes, somewhere around here, are generally swollen during strep throat. Substrain of group A strep produce erythrogenic toxin, which, interestingly, this exotoxin is encoded by a temperate bacteriophage, an example of phage conversion. Let's see. Scarlet. The toxin attacks the plasma membranes of capillary endothelial cells, leading to scarlet fever, a disseminated fine red rash on the skin, and strawberry tongue, or red rash on the tongue. And that's what we're looking at here in B. Oh, over here, sorry. And so severe cases may even lead to streptococcal toxic shock syndrome, which results from massive superantigen production that leads to septic shock and death. So acute otitis media. If you know anyone with kids or have kids yourself, you've probably dealt with these, numerous times. It's so acute otitis media, basic ear infection. 3 months old to 3-year-olds get these fairly frequently. It's the second leading cause of second leading cause of pediatrician visits under 5 years of age. It's the leading for antibiotic prescription. Now, in this case, most all the time, that is definitely caused by bacteria. So, at least antibiotic prescription is appropriate. So we can have pus in the middle ear, bulging of the tympanic membrane, inflammation, swelling of eustachian tubes, fever, nausea, vomiting, diarrhea, and preverbal babies and toddlers. The ear tugging is one of the observable signs you look for, or behavior at least. Among neonates, it is Streptococcus pneumonia is the most common cause, but it also can be E. coli, Enterococcus, group B strep. In older infants and children younger than 14, strep pneumonia, Haemophilus influenza, or Moraxella catarrhalis. And I'm not worried about that. Okay, any blockage of the eustachian tubes, with or without infection, can cause fluid to become trapped and accumulate in the middle ear, referred to as otitis media with effusion. Accumulated fluid offers an excellent reservoir for microbial growth, and consequently, secondary bacterial infections often ensue. Children have more upper respiratory infections in general, and their eustachian tubes are also shorter and drain at a shallower angle. Young children also tend to spend more time lying down than adults, which facilitates drainage from the nasopharynx through the eustachian tube and into the middle ear. Bottle feeding while lying down enhances the risk because the sucking action on the bottle causes negative pressure to build up within the eustachian tube, promoting the movement of fluids and bacteria from the nasopharynx. So this figure, we have the healthy one, the healthy tympanic membrane on the left. You see some middle ear bones there. And then on the right, torn membrane, erosion of inner ear bones, mucus buildup. That's pretty gross. All right, diphtheria. So diphtheria is caused by Corynebacterium diphtheria. It's club-shaped, gram-positive rod. Belongs to the phylum Actinobacteria. So dipteroids are common nasopharyngeal microbiota. However, some strains become pathogenic because of the presence of a temperate bacteriophage-encoded protein, the diphtheria toxin. So diphtheria is typically a respiratory infection of the oropharynx, but can also cause impetigo-like lesions, though it's not present here, on the skin. Although it can affect people of all ages, it tends to be most severe in those younger than 5 or older than 40, commonly transmitted by droplets and aerosols produced by coughing. So again, the diphtheria toxin, I think I mentioned a few chapters ago, is an AB type toxin. One of the signs of this infection is the formation of the pseudomembrane in the back of the throat, composed of dead cells, pus, red blood cells, fibrin, bacteria, to cover the nasal cavity, tonsils, pharynx, and larynx. Oof. Intubation sometimes required. Broad-spectrum antibiotics typically employed. So the toxoid vaccine here for diphtheria. This is the D in the DTaP, and in the Tdap, and the DT, and the TD. Diphtheria, tetanus, pertussis, acellular is what these things stand for. The capital letter means a full strength dose. Now, children should get 5 DTaPs total, with a TD booster every 10 years. I got my last booster, I think it was the Tdap, 2013 or 2014. I was a student at U of L at the time. And I was like, hey, it's been a long time. I should get a booster. Bacterial pneumonia. Because I will say, when you're the health system at U of L's better than what you have available as a student to you at Murray, unfortunately. Yeah, that stinks. Okay. Bacterial pneumonia. So again, pneumonia is the general term for the infection of the lungs that leads to inflammation and accumulation of fluids and white blood cells in the alveoli. Pneumonia can be caused by bacteria, virus, fungi, and other organisms. It's mostly bacterial, though. It is a prevalent, potentially serious infection, caused more than 50,000 deaths in the United States in 2014, as the alveoli fill with fluid and white blood cells, which is called consolidation. Air exchange becomes impaired, and patients experience distress. Infection of the pleural membrane is called pleurisy. All right, so when you look at that on an x-ray, there's the consolidations, the lesions. I guess consolidation sounds nicer. Okay, the most common cause of community-acquired bacterial pneumonia is Streptococcus pneumonia, which again is a normal microbiota of the human respiratory tract. And here it is in, blood culture. Is this from our blood culture? Yikes. Okay. I was going to assume that was from a mucus culture. Okay. So the pneumococci initially colonize the bronchioles. Eventually, the infection spreads to the alveoli, where the capsule interferes with phagocytic clearance. Autolysins like LYTA, which degrade the microbial cell wall, resulting in cell lysis and release of cytoplasmic virulence factors, including pneumolysin O. It's a pore-forming protein that damages host cells, promotes bacterial adherence, enhances pro-inflammatory cytokine production. The resulting inflammatory response will cause the alveoli to fill with exudate rich in neutrophils and red blood cells. As a consequence, the infected individual develops a productive cough with bloody sputum. So Haemophilus pneumonia. Encapsulated strains of Haemophilus influenza are known for causing meningitis. Chocolate agar. That's more of a milk chocolate than a dark chocolate agar. Whenever I made chocolate agar, it always came out darker. Because remember, this is where you take blood, generally defibrinated sheep's blood, and you cook it instead of just pouring it into the agar to make a blood agar plate. Maybe there's some other stuff in there. But yeah, that doesn't look as much like chocolate to me. All right, so this is a small gram-negative coccobacillus found in the pharynx of the majority of healthy children. However, Haemophilus pneumonia is primarily seen in the elderly, so it's spread by droplets and aerosols produced by coughing. This is pretty fastidious. Oh, okay. It only grown on media with available factor X, hemin, and factor 5, NAD, like chocolate agar. Thanks to the vaccine, serious cases of Hib disease have dropped by more than 99% since 1991. This is a conjugate vaccine. So Mycoplasma pneumonia, caused pneumonia, is generally referred to as walking pneumonia. So this is caused by Mycoplasma pneumonia. That's a pretty predictable name, right? From the name of the... So these are common in crowded environments like college campuses, military bases, spread by aerosol. It's often mild with a low fever and a persistent cough. Now, these bacteria do not have cell walls. They use a specialized attachment organelle to bind to ciliated cells, and that's what's indicated here. Yeah, and of course that hinders the proper function of the cilia when you got this mycoplasma attached. Chlamydial pneumonias and psittacosis. So Chlamydophila pneumonia. So it's been renamed at some point. And Chlamydophila psittaci. And Chlamydia trachomatis, of course. These are all obligate intracellular parasites. Psittacosis is a zoonotic disease that affects domesticated birds. Trachomatis can cause pneumonia in infants. So mild to severe pneumonia and bronchitis. Diagnosis of chlamydia by culturing tends to be difficult, obviously, because it's an obligate intracellular parasite. So they require multiple passages through tissue cultures, but recently a variety of PCR and serologically based tests have been developed to enable easier identification of these pathogens. Tetracycline and macrolide antibiotics are typically prescribed for treatment. Healthcare-associated pneumonia, Klebsiella pneumonia, Staphylococcus aureus, and then proteobacteria like Escherichia, Proteus, and Serratia tend to be the most common genera associated with healthcare-associated pneumonia. Now, there was a study that I need to dig up again because I lost it, but it showed that particularly in facilities that care for geriatric patients, that cases of healthcare-associated pneumonia were correlated with lack of compliance in the flu vaccine and the healthcare. I just explained that terribly. But the more healthcare workers that avoided the flu vaccine, that resulted in more healthcare-associated pneumonia in older patients. So if it's in an elderly or immunocompromised patient and it's Klebsiella, there's a distinctive currant jelly sputum that is a product of the lung necrosis. And this version is frequently fatal even when treated. And this is the case in that study, is that obviously, when you're talking about an old population that's immunocompromised to some degree or another, and they get pneumonia, you're going to have a mortality rate associated with that, right? So Pseudomonas pneumonia. Pseudomonas aeruginosa, of course, cystic fibrosis patients are particularly vulnerable to this. Part 2. John's chest radiograph revealed an extensive consolidation in the right lung. His sputum cultures revealed the presence of a gram-negative rod. His physician prescribed a course of antibiotic. And let's see, he also ordered the rapid influenza diagnostic test for type A and B influenza. And let's see, John's condition continued to deteriorate, so he was admitted to the hospital. Tuberculosis. One of the deadliest infectious diseases in human history. Although tuberculosis infection rates in the U.S. are extremely low, about 1/3 of the world's population is infected with Mycobacterium tuberculosis. 1/3 of the world's population. So we're almost to 8 billion? 1/3 of that. So Mycobacterium tuberculosis is what causes it. Obviously, there are 9.6 million new TB cases and 1.5 million deaths worldwide in 2014. So the bacteria will enter the alveoli. I think we showed this droplet nuclei containing tubercle bacilli are inhaled, enter the lungs, travel to the alveoli, and the tubercle bacilli multiply. Immune cells form a barrier shell around the tubercle bacilli called a granuloma. The granuloma shell breaks down, and the bacilli can escape and rapidly multiply, forming more tubercles. So, and again, they survive the macrophages because of mycolic acid, and if they're not eliminated, it'll progress, causing an inflammatory response, accumulation of neutrophils and macrophages. Several weeks or months may pass before an immunological response is mounted by T and B cells. Eventually, lesions in the alveoli become walled off. So bacteria continue to be released into the center of the tubercles, and the chronic immune response results in tissue damage and apoptosis induction in a process called liquefaction. The creation of a gaseous center or an air pocket where the aerobic tuberculosis can grow and multiply. They, as mentioned there, rupture. But they can also invade the pulmonary capillaries and can spread through the bloodstream. And this is known as military tuberculosis. I don't know why exactly. Where are we at? Okay, good. So these rupturing of the tubercles also facilitates transmission through aerosol and droplets. Well, droplet aerosols, right? Because these droplets can be very small and stay aloft for a long time, special precautions are necessary when caring for patients with TB, such as use of face masks and negative pressure ventilation and filtering systems. And so the Bacillus Calumet Guerin is the vaccine for TB. It's not widely used in the U.S., but is often given to infants and small children in other countries where TB is common. Does not always protect people from getting TB. This is an attenuated live bacteria. Okay, so its efficacy isn't 100%. What is its efficacy? BCG efficacy. Let's take a quick look. Oh, this looks promising from 2016. Why don't we have an effective tuberculosis vaccine? Oh, sorry. Success of a pathogen. Well, it's... Okay, I'm not going to... I just wanted to see freaking efficacy as a number. Quick number. I don't need to go down a rabbit hole. Oh, here we go. So 60 to 80% efficacy against severe forms of TB in children. That's good enough. All right. Sorry, I just got curious there. So that's actually higher than the current going into phase 4. What was that other vaccine? The RTSS. Malaria vaccine, which is only like 35%, but 1 in 3 is better than 0, right? Okay, the tuberculin skin test. This is still commonly applied in the United States, and this was in that hypersensitivities chapter. Now, if you did, that's how I know I didn't. If you got vaccinated against the BCG, or if you got the BCG vaccine against Mycobacterium tuberculosis, you can easily get a false positive. And what's used to verify that is, so the tubercles in the lungs can become calcified, forming what are called GON complexes, GHON, and these can be seen on the X-ray. All right, this is a summary. Didn't mention Q fever. And here's diagnostic tests that are employed. Legionnaires' disease, so Legionella pneumophila. This was named in 1976. It was an American Legion convention that this occurred at, this initial outbreak. But there was an outbreak in Wisconsin in 2012 that I want to mention briefly here. There we are. 2010. Here's the story in 2012. It took a while to track it down. But a decorative fountain in a hospital lobby was the source of the disease. There were 8, I think this infection, there were 8 people that got infected. Yeah. All 8 people that caught Legionnaire disease spent time in the lobby, and they weren't patients. There weren't any existing patients that caught it. Here we go. None of the patients with Legionnaire's disease was an inpatient at the hospital when exposed. And then basically they were able to track its source, the point source of this infection, by package delivery, where the person never went beyond the lobby. So this prompted a bunch of hospitals in Wisconsin to get rid of their decorative water fountains. And so you would need, decorative fountains in hospitals aren't great ideas. Legionnaire's disease also very common in the condensate around air conditioning units, which I don't know. Well, I used to play in all that as a kid. I didn't have a tablet. None of that existed for us. Anyway. Oh, right. This is for influenza. Good. So there's a little bit about Legionnaire's disease and Q fever. All right. Again, so bacterial causes of pneumonia, of course, are Chlamydophila and Chlamydia, Haemophilus, Klebsiella, Mycoplasma, Pneumococcal Pneumonia, Streptococcus, Pseudomonas aeruginosa. This is a summary of what I went over. So we're moving on to viral infection. Oh, running out of time. All right, I'm gonna call it, and we'll go over viral infections of the respiratory tract on Wednesday. That's about right. All right. Here's my awkward sign off as I go and find the streaming live broadcaster thing, and I turn it off. Unclicking it. All right. See you.